So can we kick this off, and I'll give you guys start you guys off with a little case history here. So this is a patient of mine. His name is Bear, and he had multiple fractures from an MVA on his is it his right? Yes, his right right ulnar radius, and it literally shattered. And the surgeon did the best job that they possibly could do, and they plated, but we never got union of the bone. And you can see actually in this one right here, I'm sorry, it's not super big, I can't make it bigger, that you can see there's multiple fragments all the way through here. And then we really do not have a really nice union of that ulnar at all. And so this dog was like this for 5 months, and he was completely non-weight bearing. So he came into us, basically, we were given 6 weeks to get him walking and get him active, or they were going to take the leg. And the owner really didn't want amputation to happen. So we were like, okay, let's go. So we did 5 shockwave treatments with him. After the first shockwave treatment, he actually started toe touching in the room, which was absolutely phenomenal. We had lots of tears. It was a very emotional thing. And by the 3rd treatment, he was weight bearing. And by the end of 5, he was up to half a mile walks. And we saw him 2 months ago for x-rays, and there is almost no space now where that ulnar is. And the density has increased significantly because we were worried about pathological fractures. But between therapeutic exercise, underwater treadmill, and shockwave, this dog literally is now, his mom was saying to me, like, he's walking over a mile, he has no pain, he doesn't whimper. He was starting to get aggressive when he came into us because he didn't want anyone near the leg, and his whole forelimb has filled in. So, you know, it's quite awesome when you get to really be part of a journey that could have ended so badly, but because of using multimodal things together, you can end up in a position that this dog's got a really good life, and that's quite a privilege. I'm going to just talk, and please, everybody, this is not me lecturing by any means. This is meant to be a discussion group. So let's discuss about the multimodal effects that shockwave can be part of, especially when we're talking about manual therapy. And one of the things we started off talking about just before we started was about how important it is to really, really think about the goal of our cases, and then work our way backwards as to why the things that we are putting in our plan is so very important, and always asking the question why. So understanding the true use of modalities and the true use of every skill that you're going to apply in practice is so important, because, you know, we can take things as individuals and go, oh, let's give the dog a chiropractic adjustment, and then let's stick it with needles, and then let's do shockwave and Therics all in one session. And then the dog can't walk for 3 days because we've created such a healing reaction and such an inflammatory reaction that it's really counterproductive, and we've taken 3 steps backwards instead of taking a couple of steps forward. So one of the things that I always look at when I'm dealing with any patient is how the nervous system is reacting at that point in time, because everything we do as practitioners is geared towards dealing with the ascending and descending pain pathways. And it doesn't matter what you're using, whether you're just using your hands or using a multitude of different things. We have to be exceptionally aware of that our goal is to dampen the descending pain pathway, and to allow for endogenous opioid response, to allow for enkephalins and serotonin and dopamine pathways to work. And if we are overwhelming those pathways, and if we're overwhelming the nervous system, we're going to get a healing crisis that is not positive. And I think that's something that we really do need to talk about a lot more in practice, because you learn all of these things when you go to college, or you do your CRI or CCRP course, and they're like, this works great with this works great with that. And that's totally true, but we've got to take each patient on a patient by patient basis. Terry, what do you guys think? You're in practice every day. What do you think about what we're talking about?
I would fully agree. I mean, it, every time they come in here, we do an exam, and every time we assess what they're feeling and what the owner says to us, and it, like, for me especially, it'll dictate what I do that day in terms of my exercises or the laser or even the shockwave. Like, if they're super painful, I'll be mindful of what heads I choose. And I don't always stick with what I did the last time, because it may have been worse for them, or it could have been really good. So I fully agree with that. I feel like sticking with the same old doesn't really result with a good outcome if it's not working. So
absolutely. And especially when we're looking at things like modalities, I feel like right now there's this huge competition amongst the modalities, right? Like, and Cindy's laughing because we've talked about this quite extensively, and she met my my amazing counterpart, who is the most phenomenal functional medicine veterinarian, and we talk about this all the time, about when is the right time to use what treatment protocol, right? And one of the reasons I love spending time with Cindy is every time I'm with her, I learn something new about the machines and how they can work. Like, Cindy, one of the things I'd like you to share here is talking about how when I went to school, when the Ark was being built, we always got taught, basically, go to pain tolerance as far as intensity goes. Go as hard as you can for as long as you can. I mean, I must say, and I'm patting myself on the shoulder, I that is not how I do things anymore. But way back when, that was how we were taught, right? Is go as hard as you can for as long as you can until the dog can't take it anymore, and then kind of ease up. But you've been talking about going at much, much lower frequencies. So can you share some of that?
So what we're going back to is the biological mechanism of mechanical transduction. And what we noticed over the last 3 years was when we actually started analyzing the energy density that some of the piezo wave users were using, it was not a lot of energy. So then we started, discussing the fact that, at a very low energy, you can turn on the process of mechanical transduction within the cell and not create a huge inflammatory response. So by doing this and using the low energy, we can not always, but often avoid that inflammatory, painful issue. And in my mind, as a biochemist or a physicist, why waste energy? So that's a big topic that we've been discussing, and we do have cases that have been accepted to Frontier. So we're baby steps on proving this, but those cases were done at 0.03 millijoules per millimeter, and they show healing of the supraspinatus. So in like 3 or 4 treatments within 3 weeks. So what soft tissue doesn't take a lot to heal. And we're even seeing that more and more in bone, depending on the cases. I think the more is better is not always true, for sure. And we're getting more and more results with lower energy, and our owners and our dogs are happier. So that's, the truth is, or the evidence is anecdotal in results, in that it's not published literature. But the science, if you dig into the science of what's going on in a cell, the science is real. So I'm happy with that, and we will prove it in a clinical setting. But that makes sense.
Mm-hmm. So I'm gonna throw something in today that my husband's an acupuncturist and a chiropractor, and he's a phenomenal acupuncturist. He's one of those incredibly intuitive acupuncturists, which is awesome to be around, but it's also frustrating sometimes when you go, hey, why did you pick that point? And he's like, because I couldn't feel chi here, so I used it. And then people go, oh, I have never been this pain-free in my whole life, and so they move on. So we've been talking a lot about acupuncture and fascia and the Sanjiao system, or you guys might know it as triple heater in acupuncture. And the more we go into the old texts about Chinese medicine and acupuncture and things like that, the more correlation we're finding between myofascial pain and meridians. So when you look into Chinese medicine, particularly if you look at the old texts, they talk about surrounding the dragon. And what that means is really you surround the area that is painful. And the kind of more you dive into this huge black hole of literature, there's a guy called Mark Seams who is, I would say mildly controversial, but he's amazing as an acupuncturist in the human world. And a woman called Kiko Masimoto. And all of these people have really been focusing more and more on what is a trigger point, what is an acupuncture point, and the correlation between those two have really kind of started to overlap more and more. And, you know, we can go into all the pathognomonics of fascial adhesions and myofascial trigger points and all of these different things. And we love to rename things all the time, right? But most of the things that go wrong in the body, whether it is structural or functional, is because of bad biomechanics, compression, and stagnation. And what I mean by that is, if we look at something like I've been doing this for 20 years. So it's interesting how trends have changed through veterinary medicine. So 20 years ago, it was all about spinal pain and hips and some elbows. Okay. But we never really, and I was actually talking with my medical director today, and I said, don't you think it's funny that 15 years ago, we did no cruciates? Like literally, it wasn't even a thing. It was all like, oh, the dog's old, it's got hip dysplasia, we'll give it meds, and on they went. And now we've got so much more knowledge and we know so much more, but why all of a sudden, well, not so all of a sudden, I suppose we're just more aware of it, but like, why will a cruciate go in a Yorkshire Terrier as well as a pit bull? And we go, oh, it's a degenerative knee. But why did that knee get degenerative to start with? Could be partially genetic, but at the same time, is it truly genetic, or is it because of bad gait, bad composition, bad propulsion, bad muscle distribution and muscle activation? Is that the issue? Are we getting, is our vastus medial too weak? So we're getting the vastus lat to pull it right over so that we're getting constant friction that's going on there. Or, and then we're getting our sartorial compensations and our pectineus goes into spasm. And then all of a sudden, the newly found iliopsoas syndrome, which is now the hot spot for the last 3 or 4 years. Everyone's got an iliopsoas all of a sudden. But is it truly that? Or do we have to unpeel the onion, so to speak? So, a lot of the time people get really caught up in functional, they get really caught up in structural, but we really have to evaluate the two together. And that's where, for me, I think it's such an important part to stand back a lot of the time and watch the dogs move and how they carry themselves in a gait analysis setting, so that we can really determine where the pieces of the puzzle are coming together. And for me, it doesn't matter really if it's chicken or egg. We've got to attack both of those things, whether it's structural or functional. But we do have to address both of these things concurrently, because otherwise we're not going to move ahead in life. Does that make sense? Okay, so does anybody have anything to add at this point?
So I do a little bit. I think where we kind of, or where I see we miss, is observing the animals when they come in, because we're in a hurry, or we're on a time schedule, and taking the time to watch them walk, and hopefully free if you can't have a room or whatever. But that's and feeling. So that's a big thing that I have to stress when I go in to do my demos, is we're moving tissue with a piezo wave and we're turning on mechanical transduction, but it's not magic, and your hands and your eyes are still very valuable.
Absolutely. And, you know, if you're really looking at gait analysis, the best gait to look at is a trot, because it's a 2-beat gait, right? So we're able to really look at things working on the diagonal and identify them. When dogs walk, it's also very helpful because you got your 4-beat happening there. But at the same time, 2-beat gaits really can bring out those weaknesses. So, you know, doing the combination of the two, I think, is really important. And on top of that, and I'm glad you brought that up, Cindy, I think the other thing that we really need to consider is putting together, and it's funny, I was talking with a couple of well-known rehab people about this, is almost creating a document where we put together functional exercises that break down certain muscle groups and certain movements so that we can identify dysfunction a little easier. So, you know, in your rehab courses, we're always talking about like, okay, sit to stand. And sit to stand is a wonderful, wonderful exercise, but it's like a burpee, right? It uses everything in the body to get where it needs to go. Yes, you can section it down and go, oh my gosh, that dog is really cranially loading. He's externally rotating his tarsus. He's externally rotating his hip to get into that movement, but it happens fairly quickly. So, you know, breaking things down, just doing strength testing. So, you know, lifting each limb and seeing, like, graded out of 5. Where is this dog today? Is it a 3 out of 5 where we get a little dip, but we're still stable? Is it below 3? Is it above 3 that we're like not moving at all? Having those pain mechanisms or those functional mechanisms in place, especially in your notes, really helps guide you as to whether you're in the right direction or not. Even little things, you know, going from sternal to sit, going from a lateral recumbency to a sternal position. Backward walking is something that I constantly do with my clients at almost every session to see how they're able to work through those extensor muscles, because that's something they never do. Little things like that could be really beneficial when you're evaluating structure and function together as to how is the body operating. So in a lot of our cases, particularly in the pelvic limb, we see a lot of atrophy in the glute med and in the hamstring muscles. So when you put the dog in a position where they're not able to utilize their hip flexors, you get a very, very different picture when you're only allowing them to use their extensors as they're going into that backward motion. So doing things that you wouldn't always think about and you use as an exercise, doing it as an evaluation is a very important part of being able to see how those muscles are activating and working together. If they are synchronizing, are they actually working in the right activation that they should do, or are we using compensatory things at that point in time? So something to think about. And a lot of us don't trust our hands. Cindy was saying that earlier. We really don't. We're like, I don't know. Am I feeling this? Am I feeling this? It takes, you know, that 10,000 hour rule. It's a real thing. But you also have to have a little bit of faith in what you're feeling. And one of the things that I stress all the time when I teach is always start with the normal side, because we all do it because we're busy, right? Oh, this dog had a right TPLO. No. So we fly into that right TPLO and we're like, cool, let's see. Okay, yeah, there's some crepitus. Yeah, we still got a little bit of movement in the joint, but we forget to look at the other side. And a lot of the time, that side could actually be almost as dysfunctional as the other one. And we miss it. And we don't understand why this dog is not doing well and why they're not performing at a higher level and kind of recovering as they should do, but it's because we have concurrent issues going on at the same time. So lots of touchy-feely.
Lots of touchy-feely. And with your senior dogs, so this is, I always ask the same similar question, but I get this all the time. With my senior dogs, and there is so much going on, are you picking the most painful area first, or are you picking the most needed for function first? Or how do you prioritize your treatment plan when you have, like, so my corgi with severe LS, The right leg hind shakes and is atrophied. But he's dragged his front toes since he was 4 years old, and he's lame left front. I mean,
Do we know why he has a lame left front?
I mean, you can see it. It's like,
but why? Where's the why?
The why is the peddler's child who doesn't get any diagnostics.
I mean, is it a neural issue? Is it a biomechanical issue? Is there an angulation of the carpus?
Yeah, I mean, he's a corgi. So all the legs go the wrong way, for sure. But he's literally still functional 95% of the time. I mean, my choice has honestly been to treat pain through the hind end and the roots off the spinal cord, because for me, the hind end is the motor. So I always go to the hind end before the front end.
So I would say in that regard, I think with anything that we do, we've always got to address pain. Because anytime that the pain is not moderated to a level, the body cannot heal. So we always have to address pain first. And again, that's why everything is very much like an onion, right? We've got lots and lots of layers. So, but you can't ignore the left front.
Right.
Because if the left front has been an issue since he's been 4 years old and he's now
14.
Okay. So whether it's something, and it could be something as simple as he's got more laxity in his carpus, right?
Right.
So he's got, I mean, has he got a discrepancy as far as angles go in his carpus?
I would say, yeah, it's a little hyperextended. Yeah.
Okay, so let's say we've got a hyperextension on the left. If you think about that biomechanical pathway, right? What that means is if we've got hyperextension on the left, that means we're going to have a little bit of external rotation or a little bit of flexion at that elbow most of the time. Okay. Mm-hmm. And so if we look at the scapular levels on top, you're going to see a dropped scapula on that left side, and you might even see a little bit of winging of the scapula. So where it kind of comes out. Okay. So that's already creating a leg length inequality. Right.
Yep.
So if we've got this joint dysfunction, then we're going to get tightening of the flexors from the carpus all the way up to the elbow. So we're already going to have then shortening of that elbow, so we can't fully extend, right? Then we're going to get winging of the scapula, so we're going to have less strength through the infraspinatus and the subscapularis, and the lat dorsi is going to become hypertonic on the other side. And so we're going to get the diagonal, because now we've got a leg length difference, right? So this left has dropped, this right one is up. So now we're going to get our little head bob too, because that's happening. So brachiocephalicus is going to get tight, sternocephalicus is going to get tight. And so the paraspinals are going to get a little bit loopy. And right at that like T11 to L1 area, we're going to get some transference to that right hind. Mm-hmm. Okay. So that leg length here on the left side, with the right one being up, is already causing a biomechanical mess onto that right hind, because now he's short striding. Mm-hmm. Because he can't fully, I'm just hypothesizing, I haven't seen your dog.
No, you're I mean, he's pretty different gated.
Yeah.
I don't want to call him crippled.
And I mean, if you watch him slowly, you may find like he doesn't fully extend that elbow, so we're not getting a good stride length in front. Right? Which means that we've got a limited stride length at the back. So we're not using our extensors. So we lose our hamstrings, we lose our glutes. Now we're getting fasciculations, because now there's pain because the joints are now being compressed, because we're not getting that full range of motion. And so anybody who looks at him would be like, oh, paraspinals, iliopsoas, sartorius, right? Mm-hmm. Super tight. Gastrocs are going to go into spasm because of the lack of extension. And so we're going to start toe dragging. So we may even have some cranial, a little bit of cranial tibial stuff, because we can't lift that leg because everything's shortened. And now we've got all these trigger points. So.
But we don't want to put him in a healing crisis. So we have to pick a corner or an area each time we treat him.
Correct. But what if we also address the structural stuff at the same time? Right? Like, what if we started him in a moderate stability brace on that left front?
Okay, no, that makes sense.
So we're never going to win if we have this constant leg length inequality that is causing that compensation in the back end, which is never going to allow him to have the proper stride length because of what's happening in the fore. So what if we treated the stability in the front leg, and all of a sudden, instead of him being dropped like this, he's like this. So the huge traction that is happening and the huge issue that is going on through the soft tissue to try to compensate because of the leg length inequality is now a lot more mild. So things start to relax a little bit more. And then all of a sudden you're like, oh, I treated his shoulder with shockwave, and those trigger points that have been there for the last 10 years haven't recurred as quickly.
Yeah, and I think that's the problem is I treat the immediate thing and it's not the cause. Or I mean, we all do it, but
absolutely. But
where
that's
is the cause? Yeah.
And that's the why.
Yep.
Right. So one of the things in practice is if we keep on having the same results time after time, we are probably missing something, or we are dealing with something that we cannot change on either a neurological level or on a structural level. So if you have severe hip dysplasia and we can't change it, or we're not going to change it, or whatever it is, and the structure is there, we are going to keep on having the compensations show up time and time again, right? Because we can't change the structure that is creating the functional compensation. But if we started doing gait reprogramming with what we had, so we're not going to take a dog with severe hip dysplasia and make him do backups, right? Because he's going to end up on his butt because he's got no extension in those hips. But if we started offloading the bicep and we started decreasing the stress on the tricep and we started using paraspinal strength as opposed to just letting that hindquarter atrophy and end up with Rocky Balboa in front with these enormous shoulders and these very shortened neck and no range of motion, which is eventually going to end up with osteophytes or something happening in the shoulders and some potentially degenerative elbows. We may not be able to change the structure in that form, but we can also do gait reprogramming at the same time so that we can change the way the distribution occurs. And I think also it's never really too late to make enough change that the dog can be more comfortable. Mm-hmm. Like, you're not going to put him in a very hard static brace because he's probably past that point of being able to tolerate it, and it would be too much of a shift. And that's where it's important again to gauge your goal, right?
Yeah.
And know what your goal is. So if you look at shockwave, I mean, one of the reasons why I love shockwave so much, and it doesn't take much for me to go off on the shockwave tangent because I love it as a modality, and it's my favorite modality, if I must be honest, because it works on so many levels so much faster than other modalities and faster than what sometimes my hands can generate. So if I'm looking at a tendinopathy, there is only so much cross friction that a dog could tolerate. There is only so much activation that a laser can create. Whereas I'm always looking in soft tissue and fascia, I'm always looking for blood, right? So I'm looking for angiogenesis, because if we've got a good flow of blood and we've got all the things there that can create a change in our angiogenesis and our vascular endothelial growth factors and all of these things to actually stimulate healing and stem cell development and all of that, like, if I can do it quick and easy, I don't see why I wouldn't, but we're always looking for something to be a little harder than what it does. But if we use the appropriate modalities that we've been given, and the caveat to that is that we have done our diagnostics to be 100% certain that we know what we're treating, that we're not just shooting in the dark and going, well, I think maybe could be possibly 5 of these things, and I'm going to hit all of them, because if I throw enough darts at it, something's bound to hit, right? We have to be so much more specific in our treatment patterns and what our goals are, because if we really do that, and we systematic in our treatment, and we systematic in our thought process, then things happen a lot faster than whether we're trying to just do a little bit here and a little bit there and a little bit there, that never really gives us the gains that we're looking for. So, even when we're talking about trigger points and things in the back, that's why the linear probe is so nice, because you can kind of like smash out a whole bunch in a quick period of time, whether they're latent or active, it doesn't matter. But making sure that you are addressing like the painful, as you were saying, like the most painful trigger point, right? That we know is creating weakness, even if we don't have atrophy, which is very pathognomonic of trigger points, is your weakness without atrophy. But you can actually reproduce that pain, which is amazing. Like, if you think about that you can actually be diagnostic without having to spend $3,000 on an MRI, by using your hands and doing an effective evaluation to actually identify, oh my gosh, when I palpate this trigger point in the longissimus muscle or the iliocostalis muscle, this and this happens under my hands. I can feel the weakness occur into here. I can feel how the dog wants to drop through that into that stifle because we've got that weakness. I can feel that twitch response. Treat it. If you find it and you can reproduce it and you know that that's where it's coming from, like, don't hang around, just treat it while you're there. It's a magical thing if you just don't overthink it. Cindy?
I would never overthink anything.
No.
That's why you spend 5 years getting your PhD, right? 4 years getting your PhD. Teach you to overthink.
Absolutely. Well, and it's the same for me in the underwater treadmill. Is the treadmill is such a huge, it's a great tool. But a mild pet peeve of mine is watching dogs do on the outside what they do on the inside of a treadmill with no correction. And
I noticed that in your practice.
Yeah. It's a bit of a pet peeve of mine because I don't see where the benefit is.
Right.
I genuinely don't see the benefit. If I have a dog that is externally rotating the hip, and we've got an external rotation of a carpus or a tarsus or whatever's going on, if I am not addressing those things and gait reprogramming and changing what is going on in a biomechanical fashion, what am I doing? I'm reiterating a bad movement pattern, which means that I'm just giving them more buoyancy, less concussion, to allow the muscle to keep on compensating into that bad biomechanical pattern. And that's not super helpful. If we can change how the dog moves and create different movement patterns by assisting and gating and using bands and doing resistance work, and I use braces a lot in the treadmill, because it allows them to feel where they should be so they can mimic that good patterning. And the more they use it, the more they pattern, the more that sticks in their brain. So, one of the things that I don't like is just seeing a dog do what they do outside on the inside, because that to me is just reiterating a bad movement pattern, and that doesn't make sense. So, and actually everything you've done in the treatment then until up to that point is null and void, because you're allowing them to go back to what they were before, instead of activating different muscle groups, different fascial planes, and changing the biomechanics. Well, I mean, and this is the thing, is like, that's where braces, and I mean, that's where people like Ben and orthopeds and those guys are very helpful, because, we hopefully may not even need braces for long periods of time. It's for a short period of time while we change either the functional or the structural, or both concurrently, to make a better joint. I mean, right. I think that's the key though, is using your hands, using your diagnostic tools, your eyes, your ears, everything, and then kind of going through your hypothesis of what you think is going on go through your differentials, kind of mark it down so that you can be very pinpointed and specific with your treatments.
I agree. Does anybody have any specific questions or situations that they've run into that Dr. Broadhurst can help you with? She's very talented at all this stuff. She just have to tell you her lecture. She's good at that too, but.
Can you go back to the trigger point stuff? Like I've been wanting to use the shockwave for it, but I don't really know how to, like, I know how to do it with my hands and I feel pretty good about that. But but you know, the dogs come in and they have the same trigger point where it was, just like you said, they keep repeating the same thing. So they can't ever really relieve it. And you mentioned using a linear head over the focal head.
So give me a case.
Oh God. I mean, every dog that walks into my room today had trigger points in their lats and triceps. But like, I guess Charlie would be one. He's got left elbow pain and had arthroscopy twice. Didn't really find anything. Now he's got right stifle disease. He goes swimming 3 or 4 times a week right now. He comes in once a week for exercises. There'll be times where the tricep insertion point will be very fibrotic and stiff and hard to move. And then there's other times where that feels good, but the lats are on fire or it's in the teres. And like he would be like a nice example where like we've shockwave his stifle and it's better. We've shockwave his left elbow and shoulder periodically. We've done a little bit of cervical, but repeatedly he'll come in with trigger points in the lats especially, and in the bellies of the triceps, and then that kind of like fibrous feeling in the insertion point. So he would be a great one that, like, after I did his exercises, it would be nice to attack that, because he's like you said, like you do a little bit of like cross fiber friction and effleurage. It's like, okay, I'm done with that. Like this kind of hurts and I don't want to do it anymore. And he gets needle shy and the whole thing. So he would be one that I would love to work on, but I don't even know how to. And like, what about the lung fields? And is it too close to the heart? And like, what about all that?
I'm gonna bring in the contraindications for this one. So basically, if you control your depth of penetration, which we do with the piezo wave very specifically, you're not going to get into your lung fields. You're not going to get in, and your heart, who cares, honestly, as long as you don't have a pacemaker. You're going to increase angiogenesis, and we're using it for ischemic heart disease. But anything with air is our enemy. Large porous, the pores in your lung tissue makes fragile, your intestines, things like that. But you control your penetration, and your focal zone is specific. Like when you use that on yourself, you know where you're using it, and you know when you hit a point. So for the trigger points, if you can feel them with your hand, they're not very deep, right? So you just have to judge your depth, which is usually a 5 millimeter, often a 5 millimeter pad, and sometimes even a 0 if you have a really surface one, and try to put 300 pulses of energy into that trigger point, and it will resolve. If you keep your finger next to it and use the shockwave at the same time, you'll feel it all of a sudden just resolve. So it's a static moment. It's a static, you can use it statically and just hold it there on the trigger point.
Do you kind of treat it like a compression technique where you start off light and then slowly belt in and then come back out again? Or do you just kind of just go for it?
I mean, I go for what the dog tolerates, but usually they're super also they're very tolerable of it because it feels good, right? Just like us, it feels, right. So in my mind, I want to look at my little counter and make sure that I put at least 300 pulses or so into that trigger point to release it. If it's super big dog and super tight, it might take 500 pulses, but you can also feel that with your hand, with your fingers. If your fingers are good, my fingers aren't good enough because I spend all my time on an airplane and a computer and blah, blah, blah. So I'm the opposite. I'm more comfortable finding them and releasing them with the piezo wave, because I can scan through a muscle and watch the dog react and be like, oh, well, that makes sense. That's often where we get a trigger point there. And then I can check the book and look and see if it looks close to where trigger points occur, and I can feel it, but the piezo wave helps me find it, because my hands aren't as good as yours probably, but super, I mean, and that dog where you've got that tightness, I would ask the question, and it's just a question, is would it be more valuable to shock wave those areas before his exercises so he uses the muscles better?
It'd be definitely an interesting, I'd probably go both ways and see what works for him, honestly.
I personally, because I do a lot of horse work, I always think about doing that therapy in the shockwave and then the water treadmill, or then the exercise, if it is a controlled exercise, not weave poles or something crazy, but super controlled exercise. But it's definitely worth playing.
You were saying that you would actually grab the linear head over the focal head for these?
Only for the paraspinals.
Oh, okay.
It's the cheater way for the paraspinals and some of the bigger muscle bodies.
It is a cheater way, but it is, especially if you've got those dogs like those IVDD dogs, where literally those longissimus and iliocostalis muscles, they're like trigger points for days. So like the linear probe is great for that. But for every other muscle group, I think doing them individually is much more effective. And one of the things that I do when I do shockwave is I actually block the trigger point. And I find that to be very effective, because trigger points are wily, and especially because if we're looking at fascia and muscle, and the way it's designed is to slide. So you may have a fascial trigger point, and you may even have a muscle trigger point right close to that. So being able to block it and really center where you're wanting to hit that trigger point, I find to be much more effective, and I have to do a lot less shocks, because I'm not constantly trying to get back onto that trigger point that is moving because of the slidage. So using a blocking technique where you're very specific with your treatment mechanism, I find is way more effective than just kind of like, oh, I'm feeling, yes, there's a trigger point here, and then I go where I get my shockwave and I try to kind of find it again. It really helps me because I'm so manual. I just find it, I block it with my fingers, and I just go right between my hands. And I just find that, I mean, sometimes after even like 50 shocks, I'm good. Like, but if I'm constantly moving it, like I have to with like a class 4 laser, which I don't, I mean, that's what I use at the moment in clinic, but I don't love that as much for myofascial, because we cannot be specific with the amount of the actual true application when we keep on moving something all the time.
Right.
So I think being static in your treatment, especially if you're finding insertional trigger points and adhesions and like fibrotic tissue, and it's super gnarly and it feels like a crappy steak, you really kind of want to just focus on that area and hold it there for a certain period of time. But what I would say again with the myofascial stuff is try to find the big perpetrator. Because remember, you've got latent and active trigger points. You always want to get the actives, but the latents can become the active. Right. But always try to hit the big guys first, because there's always one big co-conspirator that is kind of bringing all, it's like tequila at a party, right? Like the beer's just chilling, but tequila brings everybody in, and then it's just a complete disaster. So you got to find the tequila, and then you can treat the beer.
Yep.
If that makes any sense, because if you've got that one primary trigger point that you're not getting to, the other ones are feeding off of that all the time because of the shortening of the sarcomeres and the change within the integrity of the muscle and the fascia. If you don't hit that big guy, you're never unwrapping, you're never healing it enough that we can actually move forward and not have that recurrence of those trigger points coming up and again.
Yeah, that makes perfect sense. Thank you.
and you don't have to go hard. That's the beauty about shockwave, is because it's so shallow. If you think about the fascial tissue, unless you've got like 100-pound Labrador, which is like this much fat, you know, you don't have to get super deep. And don't worry too much about the lung fields unless you're really going in between intercostals and you're aiming for that lung. You're really not going to hit it. And, you know, knock on wood, I don't know of anybody who's caused any major issue with shockwave as far as an organic level. And, you know, I've been doing some research actually on shockwave recently. And one of the things we're finding is in human research is there's a beautiful, I think it was done in 2017 by, I think it was Yahata et al. And they did a research study about using shockwave over the spinal cord. And they really haven't actually found any contraindications. If anything, they found a stimulation of the vascular endothelial growth factors and angiogenesis and all of this really good stuff that helped with neurogenic reprogramming and ectopic bone formation. So in cases where we have spinal cord injury, creating ectopic bone formation and changing those neural pathways and assisting with the soft tissue damage that happens and sends messages to the central nervous system changed significantly with shockwave, and they didn't find any damage. Now, can we say shockwave is completely safe over the spinal cord? No, because we're covering our asses. And that's what we do, right? Because that's why we don't say, yes, we can do this. Absolutely, your dog's going to get better. We go, well, you know, the research says, and there's potential for, and the hypothesis is, but honestly, like the research is coming up more and more. And Cindy, you know more about this than I do, that really, would I shockwave over Hemi lamb? No. I just wouldn't do that, because that's just looking for trouble. And we've, you know, if we're going to treat that, it's got to be like with surgical permission, and it's like 6 to 12 months after the surgery. And is it really worth the risk? I don't know. I'm not the one to make that call.
No,
But
I wouldn't do that. But I do want to stress that when we think about contraindications, there's two issues. One, they have to be in the focal zone. And two, when you read the papers and the literature where they found the contraindications, the energy they used was very, very high. And the machine that we're running off of, and you guys in small animal are using, it's not high. The energy isn't good. You're not going to hit that energy. It stops your 20 on your machine is 0.4, and you have to be above 0.6 in most of those studies that cause contraindications. So again, we read, the worst part of it is we read the abstracts, we read the list, but we don't dig into the why. There you go.
Right.
So,
and again, it's all about the why, right? So and you know, it's a great, if you have one of these dogs that are recurrent, right? And it's like, also, again, we've got the diagonal and everything's moving and all that sort of thing. Mess around with it a little bit, like go, okay, is the tricep the primary, or is it because we have a glute med trigger point on the right that is not activating, that's changing the biomechanics, and so the tricep is having to be a major stabilizer. And then really like go into those glute meds, and sometimes you have to treat away. It might be a QL trigger point that's creating a functional scoliosis. So
can I just have your, please? That'd be great.
the beauty is you guys at Red Sage and you have such great clientele that they're so consistent that when you have that consistent clientele, you do have the ability to try something a little different and know whether it works or doesn't work, or what the result is, which I think is
yeah definitely lucky, but sure.
Yeah, so play with some treatments, and that's why I say it's the onion, right? You have to, it's layers and layers and layers and layers that you have to, especially in cases like what you're saying, you're talking about your patient. It's layers we're taking off all the time. But don't forget to look beyond like, oh, right stifle, everything's in that right stifle, but it might be because of a compensatory, it might be a brachiocephalicus trigger point right down at C6 that is creating so much stuff in that left forelimb that we ended up with this degenerative stifle. Because why did the stifle degenerate?
Probably because of compensation from the front end.
Right. So, you know, now we're having to toggle between the two, but what caused that front end, right? Like what was, because is it the elbow or is it referred pain coming from somewhere else?
Yeah, I think honestly it all came from cervical pain. Because it like correlates with him. Like when his neck pain is bad, his orthopedic issues are bad. And he could go from right-sided to left-sided. He definitely, like today, he felt great, but soft tissue wise, he was a disaster. Orthopedic, he did pretty okay. Like, so like, but next week it could be completely different. But I'm kind of excited to maybe try it on his cervical region. Although it's hard to get to that for me anyway. Like I have a hard time getting to like I don't know how to position him right to.
So here's a little trick which I use a lot when I'm teaching about this is don't be scared. Like laps are wonderful things, because if you have a dog or if you have a helper, even better, or the owner, get the dog to lie lateral recumbent, like, and get it to put its head in a position that you can actually almost really find that trigger point, and get the owner to hold them there, or your handler, or whoever it is. Because, you know, it's so funny because often when I teach, everybody's very like this, right? And I'm like, you know, you can move them. Like there's this amazing thing, like they move so well, but we're so nervous about, oh, the dog might get hurt. Have you seen dogs play? It's like Lion King.
Yeah.
I mean, what we're gonna do to them is probably not gonna like be major red flags here. So move the dog around. Like sometimes even with agility dogs, you have to get them into a position where you can almost reproduce that pain so that you can find the pain, right?
Right.
So with your buddy, you may actually want to kind of like go through those again, going with manual therapy, right? How is his range of motion? Is he bad in rotation? What about rotation with some lateral flexion? Does that kind of jack him up on one side? What's your flexion extension like? Like, do we need to do multiple movements to draw out that trigger point so we can treat it?
Yeah, that makes great sense. Yeah.
So, you know,
yeah, I'm sure I'll probably find more actually doing it that way.
so much more. I mean, I mean, it's quite funny because I look like I have a love affair with all my dogs, because I'm like, okay, and let's do this, and let's figure out what really makes you like a little tweaky. And you know, you use your hands all the time, so you've got that nuance of, oh, that's just a little bit not as fun on that side. Okay, cool. Let's look into that a little more, you know. And get those muscles. We always think we have to treat everything too in a very relaxed position, and that's not true.
No, yeah.
You can put something in a relatively stretched and stressed position and treat it that way. I mean, a lot of the time with the bicep tendon, there's no way that you can really get into that bicep unless you pull that shoulder back a little bit.
Yep.
It's all the stuff you learn it so that you don't kill anything, and then you adapt it to actually make it work better, right? Like
yeah,
that's kind of how we do it. And here's a dog, and he's like, oh yeah, that like, and he starts getting grumpy when he's in this position. Treat him in that position, because that's where you're going to get those fibers really kind of popping out, and all that inflammation and the issue that is creating that. Treat them in that dysfunctional position.
Brilliant.
And don't be scared of the shockwave with trigger points. You're absolutely fine. We've actually started using it in our clinic a little bit, for even like cats with urinary stuff. We're now like dragging the shockwave all over the clinic because we're doing all this really fun stuff. And I'm like, oh, let's do that. Okay. So off we go, and we try stuff, and we unblocking cats that would otherwise have to have catheters and all this sort of thing. It's really awesome. Like sometimes just messing around and getting your confidence up. And I mean, obviously with scientific and a logical thought over approach, but it really, like, some of the things that you can do are mind blowing.
Yeah, like you're actually like a cystitis or like a,
Yeah.
like what are you doing?
Yeah.
How are you doing that?
Well, that's not my end of the clinic. So I teach them how to use the machine and what could be, and then they're actually going externally, and they're doing some wonderful things.
Oh my gosh, that's awesome.
Yep.
And you feel like they're getting pretty immediate relief.
Yes. Yeah, it's amazing.
There's a couple of groups that can unblock cats for gauche surgery and do a whole bunch of crazy stuff.
Mm-hmm.
And you just have to understand the physical mechanism of what a shock wave is doing, and all it's doing is moving tissue.
Right.
It's not fancy, it's not magic, and it's not fancy, but it's moving tissue in a way that your hands can't do it, and so specifically. So there's some crazy stuff, and it is something that you just have to use and believe in, and don't be tentative of where and what you're using it for. You have to, if there's a reason, try it.
And so one thing I'd like to bring up too, because I get a lot of these, I'm sure you guys get a lot of these, is urinary incontinence after a spay. And it may not even happen straight away. It may happen further down the line. But what we've actually started to do is to treat those scars. And because of the fascial adhesions or the scar tissue, the lack of collagen synthesis that is going on around that area, a lot of these dogs start to become incontinent. So using the shockwave, because needles and other things that are more invasive in that area is very tricky. It's not something that I would advocate anybody do just because of the location and the sensitivity. But shockwaving scars is amazing. And it changes those pain pathways and that neural configuration of what has happened within that scar and around that fascial tissue. It's absolutely incredible. And within like 3 or 4 sessions, these dogs their incontinence can disappear.
Awesome.
So a little bit of thinking out the box sometimes and using your hands and using your brain can do wonderful things.
Awesome. Well, it's about time, and I appreciate Dr. Michelle for all of her time and energy. Anybody have any conclusion, comments, or questions, or we'll call it an evening?
I actually have one about the recommended energy level that you're using for treating trigger points.
So not a lot of energy. On your F7G3, you can start at 0.5 or 0.6, which is like 0.03 millijoules per millimeter squared.
And are you looking for a little bit of reaction at all, or are you just kind of
They'll react. You know, I might get up if it's in a muscle. Sometimes I might get up to 2 or 3. The energy on the F7G3. Now you're linear, you have to go a little higher. But I rarely put the machine. I don't ever push the machine above 6.
And would your reason for increasing it to maybe 2 to 3, would that be just because you're not getting a nice release from a lower intensity?
Yeah, okay. Yeah, because it depends how chronic it is, how stuck it is, and then you know the whole fascia tissue and what's going on. The more stiff, the more energy, right?
Okay.
You can think, somebody was describing it to me like a trampoline when we were talking about the human side. You know, if it's a really, really stiff trampoline, you might have to add a little more energy slower, get it to release. But if it's, you know, if it's more flexible, you know, it takes very, very little. So,
yeah, I like that analogy.
And remember, also comes down to pain perception on the dog's part.
Yeah.
The brain, we don't know what every brain feels, and that's a freaky thing to a biochemist.
Well, and Terry, if you know, my recommendation for most things is less is more to start with. Always start low, and then you can build up. But
Right.
if you kind of come in all guns blazing, and especially people underestimate the pain that myofascial creates. So rather start low and then ramp it up, as opposed to starting high and then the dog like gets the hugest jump sign of their life and tries to bite your face off.
Right.
Yeah.
Thank you.
Awesome. Well, thank you all for coming. Well, I appreciate everybody's time and energy, and thank you so much, Dr. Michelle. And
Welcome.
we will have the recording posted on our new website now. So we're pretty excited about that. Those of you that are on, if you go to our Normal Elevation Vet website and hit the resource button, you can find all of our podcasts, all of our forums, all of our education stuff right at your fingertips. So have fun and let us know if you have questions.
Awesome. Thanks, Vince.
Thank you, guys. Appreciate it. Have a good night.
Thanks.